Good morning. I'm Meg Disler. I'm the director of the St. Joe Community Health Foundation, and delighted you all are here for a very important topic. Um, a few announcements I'd like to just share with you all before we do this. This is an exciting but kind of a bittersweet moment for me today. This is my last time to welcome you all for the Prenatal and Infant Care Luncheon. Um, Quick history on this. It's my last one because I'm retiring at the end of the year, but turning it over into some wonderful hands going forward. Uh, but I wanted to share with you two other announcements kind of before that as well. Last night we had a board meeting, and one of the things the board did is they affirmed, listening to all the stories of the work that you all are doing, is that this continues to be a priority area for the St. Joe Foundation going forward. Caring for pregnant women, caring for the infants, young families up through the children age 2 is kind of the piece that we've been focused on. We know is very tough. You all see it, the challenges that they're facing financially with uh, some of the inflation that's hit households, particularly on the sustainability indices such as higher food costs, higher rent costs, and just getting access to good care. So this is an area that the foundation continues to be very committed to going forward, and I want to share that with you. Along those lines, we are very honored that we are doing a pilot project that this is the first time we're going to share it publicly, but we are doing a project on, we're calling it perinatal homelessness prevention. And so we have 4 agencies here in this community who do work on providing financial support for families who are on the verge of being evicted. And so if you come across there that are working with us on developing this strategy, we know if we can keep families housed and not evicted, it's essential to that mother's health, to that infant's health. So the St. Joe Foundation, together with a partnership with the Ascension Health Foundation, a national foundation, are putting together a small pool of funds, and we have 4 local agencies. These are not in order of anything, but Bright Point, Catholic Charities, St. Vincent, Society of St. Vincent de Paul, and Associated Churches. All of those have some of the funds that if you have a client, and the tricky piece of this is we want people who are already in case management, who are already on a sustainable pathway, and like they have a place, but suddenly they have hit a hardship such as life happens. That might be their they've got 2 flat tires. There's no money in the budget. It's either rent or it's tires so they can get to work. This is the group we have. They would be eligible for up to $2,000 for support so that they can stay housed. But they need to be a part of an existing program. This won't cover somebody who suddenly wants to get a nice new apartment or something. This is really for people who are on the pathway and something really hits the family that's troubling. We want to keep them housed. So with them, reach out to any of those agencies, Society of St. Vincent de Paul, Associated Churches, Bright Point, and Catholic Charities, and they will help them, and they would work with your case management program, but we're developing, it's a pilot to see what we can learn and can we help keep people housed and keep these families stable. So if you know of that, please feel free to refer to them. If you need assistance, Jackie Martinez can help you. As with my retirement, I won't be there, and I'm not sure that that's a phone call Matt wants to take on that one. And so I do want to now introduce to you the gentleman who I am very excited that he is the gentleman stepping into my shoes. Matt Smith is our new CEO. And I've worked with Matt quite a few times in the last several years, and I know you're going to enjoy working with him as much as I do.
Thanks so much, Megan. It was very kind of you all to clap for me. Hopefully, in the next time we meet, you'll clap again, but we'll see how that goes. No, I'm very happy trying to meet as many people as I can, get to know your organizations, doing a lot of listening in these early months. Very excited about the program that Megan announced. I know that she and Jackie have worked really hard on this, along with some other agencies. And so I think that as we've done some research about this and things like that, we know that keeping people in their housing is one of the first things that can lead to better health for the mothers and for the children. So I just want to take a moment and just say thank you for all the work that you do. It's a very stressful job that you are all in, working with the families that you do. And it's, you know, this time of the year is also a very stressful time of the year for lots of people, for lots of reasons. So thank you for all your work. I'm really looking forward to, like I said, getting to know each of you, getting to know your organizations and how St. Joe can best support the work that you do because you're on the front lines. So thank you again. Thanks for being here. We've got lots of breadsticks, so don't be shy about it. So thank you very much. And now I'll turn it over to my colleague, Jackie Martinez. So.
Thanks, Matt, and thank you guys all for braving the cold weather and being here with us today as we finish another year of these luncheons, which I find to be so enjoyable. I get to see all of you, and you guys get to network with one another, so that is so important. So I'd like to go around the room and do some introductions. We have a smaller crowd today, so it should go fairly fast. I'm going to grab a couple microphones, and what we can do is just hand off. If you just state your name, your title, and what agency you are with. And if you have any special announcements that you feel are necessary to announce to the group, please feel free to do so as well.
Hi, is this on? Yes. Hi, I'm Noel Nussbaum, and I am the lead care coordinator at A Mother's Hope.
Hi, I'm Simone Corey. I am a care coordinator at A Mother's Hope.
Hi, I'm Sierra, also a care coordinator at A Mother's Hope.
Hi, I'm Tara Held. I'm the Every Birth Network Manager at Healthier Moms and Babies.
Good morning. I'm Belinda Dean, a social worker with the Neighborhood Health Clinics.
Hello, I'm Dominique Nettles, and I am a charge nurse at Hope Center.
Hi, my name is Natasha Jones, and I'm the manager at Connect Allen County in the Lewis Plaza.
Hi, I'm Ashley, and I am part of the DNFW, which is the Doula Network of Fort Wayne, and I'm a doula in training with Healthier Moms and Babies.
Hi, I'm Renee Cleland. I am a birth doula and a certified lactation specialist. I take private clients, but I also contract with Healthier Moms and Babies. I've had the pleasure of training several of our new doulas there. And I'm also a member of the Doula Network of Fort Wayne.
Hi, I am Tristan. I am one of the doula in trainings for Healthier Moms and Babies, and I've also joined the DNFW.
Hello, I'm Diamond Mims. I'm the Children's Service Coordinator for the YWCA.
My name is Tyler Hunter, and I'm a child advocate at the YWCA.
Sharon McGee, Associated Churches Program Manager for ABC and JVM.
I'm Britte Nihart. I am the FIMR Coordinator, which is Fetal Infant Mortality Review for Allens, DeBen, and DeKalb counties.
Hello, my name is Danny. I am an OB Nurse Navigator for Parkview.
I am Brittany Wessel, and I am an OB Nurse Navigator with Parkview.
And I'm Laura Pfluger. I'm a social worker at the OBGYN Bruce Street, Parkview.
Sarah Van Alken, Nurse Navigator, also with Parkview, Fort Wayne.
I'm Abby Gaba. I'm also a social worker with Parkview, the outpatient OBGYN clinic.
I'm
I'm Emilie Singleton. I am the Infant and Maternal Outreach Coordinator at SuperShop.
I'm Delaney Baumann. I'm a psych nurse practitioner with Made to Thrive Mental Health Wellness.
Hello, I'm Andrea Caldwell. I'm a family case manager for the Department of Child Services.
Okay, and I think most of you guys know me, but I don't think I introduced myself. My name is Jackie Martinez, and I'm the Community Impact Director with the St. Joseph Community Health Foundation. Another one of my teammates is Mark Burkholder. He is our multimedia program manager, and he will be handling the camera for us today. So if you see him taking awkward pictures of you while you're eating, that's what he'll be doing. And then Meg and then Matt have already introduced themselves. So as a team, we thank you so much again. We are going to start off with just some quick announcements from our community partners that I think are very beneficial to help in the work that you guys are moving forward as you are working directly with families. So we'll have Tara Held first come up and tell us a little bit about some of the projects that are going on with the Every Birth Network. Please welcome Tara.
Hi, everybody. My name is Tara, and I'm with the Every Birth Network, which is a part of Healthier Moms and Babies. If you're not familiar with the Every Birth Network, we're a group of community partners, and we work on currently 4 major initiatives, one being safe sleep, another being maternal mental health, also for fetal kit count monitoring, and preterm labor awareness. So within the last year, we've really been focusing not only on safe sleep, but moving into, maternal mental health. Our recent meeting with our community partners, we all agreed that we need to get some more education and knowledge around what our community providers and the mental health clinicians in our area are doing and what kind of education they currently have in regards to maternal and perinatal health. Maternal mental health, as we all know, and I'm sure we're going to hear a little bit about later today, is a huge need in our community. I know Healthier Moms and Babies, we see a lot of their clients, but we just want to gather some more information on the current education that some of our providers in the area have. Long term, we're looking at bringing some education to the Fort Wayne area to assist some local providers in becoming PMHC certified through Postpartum Support International. So I'm going to pass around later some little flyers. If you want to take a handful, 1 or 2, whatever it looks like for you, to share with any mental health provider that you have within your network. We have a group of almost 60 community partners with Every Birth, but we can't hit everybody. So if there's someone you know or a network that you know, please feel free to pass this along. Your organization is welcome to share it on social media, newsletters, whatever that may be. If you have any questions about this, please let me know. I'm hoping to have some results back early next year. So next time I see you all, we can share some of the data that we've collected and talk about next steps into bringing some of those trainings into Northeast Indiana. Something else I wanted to highlight before I step away is our upcoming events called Walk and Talk with a Doc. These are a great opportunity coming up in the new year for our community of moms and families to get together and talk in a casual setting with local providers. Dr. Turner has been helping us drive this initiative, and we're talking about things from vaccinations, breastfeeding, sleeping. Our only barrier is we haven't had a lot of people come. We've had 1 or 2 at the last couple walks. So as we get these developed, also have some dates moving forward for 2026. I just kind of wanted to give everyone a heads up. These will be continuing to happen. So as you see information come out from Healthier Moms and Babies and Every Birth Network, feel free to share with your community. It doesn't just have to be moms. If a caregiver that you know wants some more information or wants to talk to a physician in a more casual setting, this would be a great opportunity. So thanks again. I appreciate it.
Thank you so much, Tara. And as she's passing those out, I'd like to welcome Emilie Singleton. She is with SuperShot, and she is also here to just tell you a little bit about some of the important news around immunizations for our community. Thank you, Emilie.
Good morning. Like she said, I'm with Super Shot. I am their infant and maternal outreach coordinator. Today, I just really wanted to highlight RSV. So we're in RSV season. Everybody knows that. We have two major immunizations or vaccinations for that group. One is for the pregnant women. That's a Brisvo. You can get that between 32 and 36 weeks. That's a hard one. Not all OB offices are carrying that. It's hard for moms to get because it is also within that window. So they can come get it through us. If they do get it between that 32 and 36 weeks, then their baby does not need to be immunized for RSV. So their baby is protected if they get it 2 weeks prior to giving birth. And we do incentive programs. You know, we like to try to encourage people to get their vaccines. So if a mom comes in and gets their RSV vaccine with us, we will offer them either a box of diapers or they can have a Starbucks gift card. Just a little something to say thank you for protecting your baby. And then if they happen to not get it or give birth too soon, then the baby can get Beyfortus, which is the RSV immunization. So one poke, ideally they would get it like right at birth, if not, 7 days later, but there's not a lot of moms or parents who want to take their babies out within 7 days, especially in this weather. So you can get it up through 8 months. But that starts working almost immediately. So that is an immunization and not a vaccine. So it is just giving the babies the antibodies straight off. So the baby shouldn't have any, downtime. They don't have to work at creating the antibodies like you would with a normal vaccine. It's been being given in like the NICUs for years. So it's not a new immunization. It's just new to like the general public. This is, I want to say, like the third season. But again, if your baby comes in and gets the immunization, then we will also give that mom or dad a free box of diapers for protecting their child. So, but we also have all other childhood vaccines. And I have business cards and some flyers if you want to know like the immunization schedules or want to be able to give those out to your clients. But yeah, thank you for having me.
Thank you, Emilie. Next, I'd like to welcome Britte Nihart. Britte is here with Allen County Fetal and Infant Mortality Review Team for here in Allen County. She's just going to update us on some recent findings, and if anything pertains to our topic today, she'll be sure to highlight those as well. Thank you so much, Britte.
Okay, I think most people here know what FIMR is, but in case you don't, as she said, it stands for Fetal and Infant Mortality Review, and it's done through a grant from the State Department of Health. I am doing it for Allen, DeKalb, and Steuben counties. I have 2 other team members that do it for the other, 9 counties surrounding. So we review the cases of fetal death from 20 weeks to full term, and then infant deaths under 1 year of age, basically to try to identify trends in the cases, things that might be preventable, or if not preventable, just ways that we can improve the situation for women that maybe have to go through it again someday. We also, part of that is we try to reach out to all the moms that we review the cases and offer them the opportunity to be interviewed, and the cases are de-identified, so it's kind of an anonymous thing, but it allows them to tell their story from their perspective, which is, I think, one of the most valuable parts. But when I was asked to share with this topic, I went back through the cases that we have reviewed in Allen County FIMR, the ones that we reviewed from 2023 through 2024 were the ones that I looked at. And I found that more than half of those involved a mother with a diagnosed mood or psychiatric disorder. Often those women are taking medications prior to becoming pregnant for their usually depression, anxiety, whatever their diagnosis may be. But upon getting their pregnancy test, their positive pregnancy test, a lot of them will kind of panic and stop everything because they don't want to do anything that might harm their baby, so they just stop all medications. This can lead to, obviously, you know, instability of their mood or their diagnosis until they come into their OB visit, which might be several weeks later, and then oftentimes are told, oh no, you can totally stay on that. We actually wish you would stay on that. But then by the time, so then they restart it, but it takes then another, you know, 4 to 6 weeks before the positive effects of that start to kick in. So it can be a couple of months of not great mood during that time if they quit without really a need to quit. So that was one of the things we've noticed. The other really big thing is that prematurity was the leading cause of death among all the cases that we reviewed. And we know that untreated or undertreated maternal infections are a big risk factor for preterm labor. And we've seen several cases where moms were prescribed an antibiotic for like a urinary tract infection or some other infection. But in the documentation, they were never asked if they actually took the medicine, if they ever filled the prescription, if they ever took the medicine, and if they did take it, did they take the whole thing? So we had one such case that really stood out. It was a patient with a language barrier to begin with, so that was difficult. But she went to an ER very early in her pregnancy and was diagnosed with a UTI, prescribed an antibiotic, came to her OB appointment about 6 weeks later, again diagnosed with a UTI. No conversation about, I don't know if that provider even knew that she'd ever been to the ER and was diagnosed with one. So she was prescribed an antibiotic again. Don't know if she ever even picked that prescription up, but at 28 weeks then was back in the ER with kidney infection and eventually septic shock. So that progressed to respiratory failure. She ended up in ICU on a ventilator, like truly almost died. And there just was never any documentation throughout all of those different visits with different providers if they knew, if each knew that the other was prescribing, and if anyone ever asked her if she took the antibiotic. So that is something that's an extreme example, but we do see that in cases where it seems like, or if a provider does go back and ask, did you take the antibiotic? Oh no, I couldn't afford to pick it up. Or I started to, but I didn't really, I forgot after that. I didn't finish it. I only took it for 2 days. So that follow-up and communication with providers, we have noted that as something that is important. And that goes for patients with high blood pressure also. We sometimes see the similar things, that they don't take the medicine that's prescribed because they feel fine and they don't really understand the need. Or maybe they can't afford it, they don't like the side effects. So sometimes doctors don't realize that they're not taking what was prescribed. And hypertension, uncontrolled hypertension, is also another risk factor for preterm labor. So from a FIMR perspective, this topic that we're covering today about safe medication use in pregnancy is very important. Thank you.
Thank you, Britt. Well, I'm gonna have to take a deep breath before I read our next presenter's bio. But I would like to introduce to you our next speaker, Dr. Sarah Turner. She is a full scope family medicine physician with advanced training in surgical and high risk obstetrics, substance use orders and pregnancy, neonatal and pediatric care, women's health, and reproductive health. She works locally here since 2016. Okay, 17. And she's also doing some teaching at the Fort Wayne Medical Program residency program. She is an internationally board certified lactation consultant and is working towards her board certification in addiction medicine and certification in perinatal mental health. She has a passion for educating patients as well as the community, and has made every effort possible in her busy schedule to be here with us today. I probably have ran her bio short, but her presentation will speak for themselves. Please welcome Dr. Sarah Turner, please.
Thank you. It wasn't up to date. I got my certification, my board certification in addiction medicine last year. So, yeah, very exciting about it. Yeah, I'll click. Thank you. So I'm going to talk a little bit about just very general medications in pregnancy and just like safe medication use. One of the things we see a lot, or I see a lot in my clinic, and I know we saw a lot with the residents, was people would come for their first OB appointment, which often is, 3 to 4 weeks after they schedule, and they have stopped everything. And especially in the world of mental health, it's usually terrible at that point. And I know Delaney's going to talk about that part, but just getting people comfortable with what they can actually take and how to use everything safely. So, objectives, we're just going to talk about the use of it, how to use them and how they impact pregnancies, to talk about like the different physiologic changes in pregnancy, and so, which I do feel like is not super acknowledged in medicine, unfortunately, because a lot of medications actually need to be adjusted and aren't. And then we'll talk a little bit about the Tylenol thing, just because it's very relevant right now. So just some quick statistics about medications in pregnancy. About 9 out of 10 women will take some sort of medication during their pregnancy, and 7 out of 10 women are taking something that is prescribed to them, not over the counter. Most common medications that we're prescribing are things like anti-infectives, so for BV, yeast, UTIs, pain medications, psychotropic medications, thyroid, anti-nausea is probably one of the biggest ones, and then anti-diabetes and anti-asthmatic. The top 3 are for infection, pain, and nausea. But less than 10% of the medications that have been developed and put out since 1980 actually have decent safety data, which is a very alarming statistic. Now, that doesn't mean we don't know anything about them. One of the biggest things is how we study medications, and the best studies come from randomized controlled trials, and we're clearly not doing a lot of those. So a lot of it's retrospective, and so that's why we don't have the best data on them. But only about 2 to 3% of medications cause, or 2 to 3% of congenital anomalies come from medications. And that's where I think like 100% of people are scared. And so a lot of times they'll call their family practice doctor, their psychiatrist, or nurse practitioner, whoever it is, and they're just like, you know what, just stop stuff until you can get to your OB. And we should be doing better, honestly. So are they safe? Again, the best things that we can do to study this stuff are randomized controlled trials, but that's not super ethical. We're going to give you guys something that might hurt your baby and you guys that don't, and we'll see who has 6 toes. I don't know. So that's not what we're doing. We're mostly doing either observational, where we follow along with their pregnancy, or we'll do retrospective. Both have a lot of biases associated with them. Retrospective is probably one of the most common ones that we do, and that one is very confounded by recall bias. So we remember that we took such and such, or how much did we take, when did we take it, what else did we take. So these are not great studies, but over time we can amass a lot of data from them. So they're not terrible by any means. They are very informational. So the biggest things that we look at in safety are, does this medication cross the placenta? And in the world of breastfeeding, does it enter the breast milk? Does it accumulate in breast milk, or does it go away? And then one of the big things that we always want to do in the world of figuring out if they're safe is have a conversation with our patients, because most of these medications fall into this very gray area. And it's a lot of risk-benefit ratio. What's the risk of the medication? What's the risk of not using the medication? And then we figure out what's right for each person. So the risk-benefit balancing, it's really what we should be doing everywhere in medicine, for all patients all the time, for everything. Giving people some autonomy and decision-making power. It definitely improves a lot of compliance with medications, but it also, when we're having those conversations and we're doing proper informed consent, they feel comfortable with them. So they're going to feel better about the decisions that they're making. And then thus decrease a lot of the mom guilt that a lot of people will get from taking medications. A lot of women feel very selfish putting any of their needs above their babies. So we need to make sure that we're considering all of the relevant information here. And so that includes that particular patient, everything about that patient, demographics, social, medical histories, family history, and then also like the data that we have available for whatever medication that is. And we want to make sure that the treatment plans are very individualized. Each patient's going to have a different treatment plan, and everybody's going to have different questions that come up, issues that come up. And we really should be talking with the patient and her family and friends, just so that, because I feel like a lot of people get, I'm trying to remember what the statistic was, 40% of people get their medical advice on Facebook, which is awful. I've seen what medical advice happens on Facebook. Some of it's great, some of it's terrible. And so the more we can get other people involved in her world, the more we're going to make everybody feel comfortable with these treatment plans. So they should also be dynamic, which means that they're going to change as the pregnancy changes, as risk changes, as everything about her changes. The plan should also potentially change. And then at the end, we do shared decision making. So with most of my patients, at the end of any conversation, you know, this is what I think, this is the data that we have, here's what I would do, what do you think? And I feel like people like having choice. They feel better about their decisions. Again, the compliance is improved, but that's really what we should be doing with everybody. Traditionally, we have always used these pregnancy risk categories. So that's the A, B, C, D, and X. And this is really falling out of favor. We shouldn't be using this as much anymore. Some people still do. And it's not totally not useful, but it definitely shouldn't be the be all end all. We have a lot of better ways to look at stuff now. So when we're looking at medication impact, we should know that A, things are trimester dependent potentially. Sometimes things shouldn't be used in the first trimester or the third trimester, but they're fine in the middle. Sometimes they're not safe at any point, but trimesters do matter. And medications sometimes have absolutely no effect. They're totally safe. They're absolutely fine to use, no problem. Sometimes we get direct impact to the baby. And so what that would be is that we're having something that directly hurts the baby. It can either be something like birth defects, so those would be teratogenic medications. And that's really, I think, where most people have their fear, obviously, a very valid place to have fear. When we're looking at the timing of teratogenicity, the biggest time is between weeks 3 and 8. Under week 3, medications are unfortunately generally going to end a pregnancy. But between week 3 and week 8, that's when we get a lot of our congenital anomalies, if they're going to happen. So that's when we can get birth defects, because that's when most of the formation of the organs is happening. Conception's at 0. So week 3 is actually, in the way we kind of measure stuff, it's week 5. So it's week 5 to week 10 in pregnancy terms. And when we're looking at timing of teratogenicity as well, we have different timing for all the different organs. So, and in the pink side of it, that's sort of the most sensitive period, and then in the green side of it, it's still sensitive, but not as much. But you can see like it's a different organs are being developed at different times, and that's where if we know what a medication is somewhat associated with, we can very much narrow down when we should or should not be using those medications. So, other things that we get are indirect impact. And so that's going to be things like a medication that drops mom's blood pressure. When we drop mom's blood pressure, we don't get as much blood flow to the placenta or to the baby. We have placental impact, so medications that maybe vasoconstrict blood vessels. So again, we got less blood flow to the baby. And then we can get growth restriction and stuff like that. And then we have uterine impact. So we have medications that potentially can cause irritability to the uterus, contractions, and then put you at risk for preterm birth. So those are all the different things that we should be looking at rather than just A, B, C, D, and X. When we're looking at the first trimester, we're going to look at worried about the birth defects, but also there are definitely medications that can cause miscarriage. Second and third trimester, we're not as worried about birth defects because at least once you hit 18 weeks, everything is formed. We have no more worry about birth defects from medications. We're worried more about cognitive, neurodevelopmental. You can still have later miscarriages and or stillbirths. But the bigger things that we see are a lot of medications that cause low birth weight, preterm birth, neonatal adaptation issues, and that's like babies that are fussy. That's pretty specific to a lot of the psychotropic medications, especially antidepressants. And then there are some medications that can increase your risk for SIBS. So that's where we were. And so just because we're past the first trimester does not mean we're out of the woods. But the risk for these things might be really, really small, and the risk of whatever it is we're trying to treat might be a lot bigger. So just because we see all these scary things doesn't mean that no medication is the best option. Giving you all a little quick introduction to pharmacology and just how we look at medications and what they're doing with pregnancy. We have two different parts of pharmacology, pharmacodynamics and pharmacokinetics. Pharmacodynamics is what is the drug doing to the body? And so that's looking at things like how does pregnancy change our sensitivity to medications? And it's usually anesthetics. We're not as sensitive or more sensitive to anesthetics. Pharmacokinetics is more what is the body doing to the drug? And this is where a lot of our changes happen in pregnancy. And again, I feel like this is a very underappreciated part of medicine. It was never part of my training, and it's something that I learned a lot later than I am comfortable admitting. So I actually learned a lot of it through the perinatal psychiatry and mental health training that we did. So, so this is looking at how are we absorbing, how are we distributing meds, and then metabolizing them and eliminating them from the body. This stuff is all very, very changed in pregnancy. Looking at absorption, we have changes in our gastric pH, we have changes in the stomach acid just sitting there, we get decreased movement in the intestines, and so in the absorption place, we do see a little bit of increased doses and decreased doses because of this. Now, not all medications are going to be, depending on where they're absorbed, be affected by this. So that's why it might be up or it might be down. In distribution, we get so much more blood. You get 40% more blood in your body. So if you're diluting that medication into almost a half extra blood, obviously you're going to have like 100 milligram dose is going to feel like 60 milligrams. So decreased plasma volume, and then increased water retention, decreased albumin. Albumin is a protein that protein binds our medications and makes it so that it's harder to move places. So these are things that in general will usually decrease the sort of overall dose of what we're feeling. Metabolism, we can get increased or decreased enzyme activity depending on the enzyme, depending on the thing. So we might get increased or decreased dose feelings from that one. And then elimination, generally we get rid of medications a lot quicker during pregnancy. So again, we feel like there's less medication from the same doses that we're taking. So the red one, the red stars, that's where we have decreased medication levels, and the green ones are increased. So most of it's decreasing our blood flow or our medication concentrations. So in terms of the metabolism changes in pregnancy, most of our medication concentrations will fall. So it feels like you're on a lot less. And this, I think, especially, I know Delaney is probably going to talk about this, but in the world of psychotropic medications, man, does this get into people's heads. And it's usually kind of later in the pregnancy, and they all think there's something wrong with them. And it's nothing wrong with them. They just aren't feeling the full dose of that medication anymore. And then when they get in their heads, they think there's something wrong with them. Why am I upset about this? I wanted this baby. What's wrong with me? Why am I depressed? You're not depressed. Your medication is just not working the way it's supposed to. And I feel like if we don't prep them for that, it can significantly worsen a lot of their mental health. So we need to increase their doses. Not everybody, but giving them a heads up and making sure they know that this is something that is probably going to happen definitely helps prevent a lot of the depression. Medication timings can change. We see this a lot in the world of methadone. Traditionally and across the United States, it's generally recommended that people on methadone should be double dosing through the day, split dosing, where they take half of the medication in the morning and half in the afternoon. Because if they don't, they're absolutely snowed in the morning and falling asleep, but then they're withdrawing at 4 in the morning. Unfortunately, we don't have medication availability with our clinics here in Fort Wayne. So if they don't have take-home doses, they are snowed in the morning and then withdrawing in the middle of the night. But there's a lot of different medications that also have this, so we have to split doses through the day. And then again, all of this can either be through the whole pregnancy or trimester specific. We see a lot of these changes happen sort of at the end of the second, early third trimester. And so a lot of people will change their dose, but then right after delivery, we get rid of a lot of that blood. All of our metabolism changes very quickly, so a lot of people have to go right back to the same dose that they were on prior to pregnancy. All right, so what medications need to be stopped in pregnancy? People should just call their doctor, their midwife, their OB, whoever it is that's taking care of them. And if they're on a medication and they don't feel like they're getting the answers, they need to be really, really like, I need to talk to somebody today because I don't know what I'm doing. A lot of people are told on the phone, just wait for your appointment, and they will. And it's really unfortunate that that's sort of the care that we sometimes give. So advocate for your patients to keep calling and harassing people until they get an answer. What medications need adjusted? There's a lot of medications that very early in pregnancy we need to adjust. Again, people should call their doctors, but the list is not super long at the beginning. It's most of the medications that very immediately start metabolizing faster, and so that's our thyroid medications, epileptic medications, pain medications, and then things like Suboxone, Subutex, methadone, and antidepressants. Now, those latter three, it usually happens later, but definitely a few patients start feeling it really, really early. And so again, we need to adjust it so that we can get on top of stuff quickly. So it is really important, and I talk to a lot of my patients who are potentially having any sort of fertility on the horizon, doing some preconception counseling. And so patients should come in and we should have a full discussion about it. What do I need to change my medications if I get a positive pregnancy test? And what do I do about any of these? Do I have to stop anything? And if someone's actively trying to get pregnant and they're on a medication that I know I'm going to stop, I'm going to probably switch them beforehand so we don't even have to worry about it later. How might that medication affect my pregnancy? Is this a medication that my baby's going to withdraw from? So I'm going to, potentially want something different. Is this a medication that I'm not going to be able to take in the first trimester, but I'm going to be able to take later? Is there something I can do instead? Are there any medicines or supplements I should avoid? A lot of people assume that if something's a supplement, a vitamin, that it's safe. Not even remotely the case. A lot of these things are very, very crossing the placenta and are not very good for babies. So they should not just willingly take all of the supplements without talking to doctors or their OBs, midwives, nurse practitioners, whoever it is. And then will I need to take more or less of my medication? That's when I try and have that conversation at the very, very first appointment because I want to get on top of them before they start getting in their heads. And I find that actually helps a lot because then they know it's nothing wrong with them. They just need to go up on their meds. And then can I keep taking this medication when I start breastfeeding? Most medications that are safe in pregnancy are safe in breastfeeding, but not all. And so making sure that they know what changes to expect would be good. And then what medications should I be taking when I am pregnant? Most people should be getting some sort of a list at their first appointment of what's safe and what's not. So if they're not getting that, I don't know, they should ask for one, I guess, but I think most people should be giving that. And I have a really good list that I meant to bring and totally left it sitting on my desk. I had a handout for everybody. If anybody wants it, I have a really good handout of things that are safe, things that are not safe, and then a bunch of stuff in the middle, the gray area medications. So yeah, I'll send it to you. That'd be great. All right. And the big one, does Tylenol cause autism? The short answer is no, it does not cause autism. And I say this as a mom of a kid with autism, who I did not take Tylenol when I was pregnant, because I hate Tylenol, it doesn't work for me. So a lot of studies have shown that there's an association. An association does not mean that there's a link, and most of these studies didn't look at genetics, they didn't look at why mom was taking the Tylenol, because a lot of the reasons we take Tylenol are things that cause autism. Fevers, for example, is something that can cause autism, among other things. So most of these studies are observational. Hey, did you take Tylenol when you were pregnant? Because I see that your kid has autism. That's how they were sort of designed, which is awful. Was the sky blue when you were pregnant? Because maybe that's what caused it too. They're not controlling for genetics, which is one of the most important things that we should be controlling for. When we look at genetics, most of these associations completely go away. And I did autism because that's what most people are talking about. ADHD was also in there. All the same for ADHD. It's not associated at all. Why was the Tylenol taken? And then there was a PhD out of Drexel University. He's an epidemiologist, which means he studies diseases. And he did this massive study in 2024. He put it out. It was out of Sweden. And it looked at 2.5 million kids. And they controlled for genetics. And they looked at why mom was taking the Tylenol. And lo and behold, no, there was no link at all. And there's some studies that even, and I'm not going to say that they're right, but there were some studies in the group of studies that most of them look at that actually showed that Tylenol was protective. I don't know that I believe that, but it definitely is pretty overwhelming evidence with 2.5 million kids that there was not a link. So the longer answer is we have very good evidence that shows there is not a link. So, all right, so conclusions. We should be doing preconception counseling with anybody who is potentially at risk of becoming pregnant or trying to get pregnant. We shouldn't be starting or stopping medications without any sort of medical guidance. It's not Facebook or Google. We should be doing risk-benefit ratios with all patients because most medications are very gray areas. They're not clear yeses or clear nos. And no meds is not always the safest option. I know Delaney's definitely going to talk about that because that's the big area is in the psychotropic part. We should be avoiding unnecessary medications, but unnecessary is the really key word there because there's a lot of medications that potentially are necessary or are safer to take than not. And then using the lowest effective dose, and then making sure that people know they need to adjust them potentially. If we're looking at resources for medication safety in pregnancy, again, the FDA pregnancy categories are not something that we should be using a lot. And so what do we use? Instead of that, ReproTox is a great one. It costs a lot of money, so most people don't have it. I don't have it. But Infant Risk is a phenomenal resource. It costs, I think, $10, and it might be $10 a year. It's well worth it. It gives you, you can see it on this one, first, second, third trimester, and then it goes 0 to 6, 6 to 12, and 12 plus months breastfeeding. And it'll give you the data and then give you the whys. It'll give you the alternatives. And then there's even a hotline where you can call 24 hours a day and be like, what about this thing? It's a phenomenal resource. I use that probably 4 or 5 times a week, easy. LactMed is another really good one. The CHAMP program is very specific to Indiana. CHAMP program is a phone number that you can register in the CHAMP program where you call and you get a perinatal psychiatrist on call 24 hours a day. They track patients, so they'll get patient data so that if you call one day and then call another day, they can look up the patient, see what they recommended, talk about next steps. It's a great resource. And then Mother to Baby is another one that I really like, and this one might be useful, especially with this crowd. It's a really good site that's very evidence-based. It's a nonprofit organization of teratology information specialists. And so they give a lot of evidence-based information. And then they also do a ton of research studies. So you can actually sign people up for research studies. Right now they're doing one on one of the Tdap, whooping cough vaccines, among other things, but that's one of the big ones that they're doing. And so this is how we get our information is patients who are currently pregnant. It's the best way to get the information that we're looking for in the ways we can. But they have a lot of free pamphlets. All of these I downloaded for nothing. And it's great because you can have them to give to patients. But then they also have a lot of great patient education handouts. So things about medication safety tips, things that you wouldn't necessarily, I'm like, never thought about that. Don't take your medication in the dark. Make sure you know what you're taking. Like, I never thought about that. That's great. Protecting your babies from vaccines, giving vaccine information, and then talking about the critical periods of development. So it talks a lot about, again, preventing any of the harm here. So, and that's all I got. Guess which one's autistic? So, any questions? Okay, awesome. Thank you.
Thank you, Sarah. They're so cute. The little one is mood. That's funny. That's how one of my twins is. Okay, so next I want to introduce Delaney Baumann. Delaney is a dual board certified family and psychiatric nurse practitioner and is certified in perinatal mental health. She has a deep passion for caring for individuals experiencing perinatal mood and anxiety disorders. Delaney is the owner of Made to Thrive Mental Health Wellness, a private practice focused on psychiatric medication management during the perinatal period. She is an advocate for increasing awareness and education surrounding perinatal mental health and works to reduce stigma and improve access to care for all individuals during this critical time. Please welcome Delaney.
Well, thank you so much for having me here this afternoon. I'm looking forward to sharing with each of you. And thanks, Dr. Turner, for your great start with regards to medications in pregnancy. So I operate a private psychiatric practice, and my patient population focus is predominantly on women during the perinatal period. As an aside, I also operate a nonprofit organization called Remembering Rowan, and we pay for infant funerals in the state of Indiana. So I feel like my personal experiences as a mom who lost a baby, as a mom who walked through pregnancy after loss, much of this has shaped my my clinical practice and the way that I care for women during this time period. So, oh, I wonder how many of the lines are going to look weird like that. Okay, well, we'll see. We are going to talk about perinatal mental health disorders. I will say Postpartum Support International changed their acronym from perinatal mood and anxiety disorders, PMADS, to perinatal mental health disorders. And I'm probably going to say it incorrectly a million times in this because they just did that. So forgive me if it's in my slides incorrectly, or if I refer to something as PMADS, that's what I'm referencing. So we're going to talk about different risks, differentiating between postpartum depression. Yes. Okay, thanks. We're going to differentiate between baby blues and postpartum depression, identify different risk factors for all of those that have really boots on the ground and are seeing these women, nurse navigators that are caring for these women, you know, in contact with them. Kind of what are the risks that are innate that we need to have some mindfulness that they may be at increased risk of having a perinatal mood disorder. And we're also going to talk through each of the perinatal mental health conditions and kind of how those may be presenting. So perinatal is a term used for the entire duration of pregnancy through a year postpartum. This is often confused with prenatal. So just want to give some definitions there. And then mental health disorders includes the group of specific mental health conditions that are occurring in the perinatal period. And these can be pre-existing conditions that these women are walking into pregnancy with a history of generalized anxiety disorder, or OCD, or they may be brand spanking new and something that they're all of a sudden now in the third trimester depressed or postpartum experiencing OCD. Let's talk about the prevalence of kind of what these look like. So we know that 1 in 5 mothers will experience a perinatal mental health disorder, and 1 in 10 men. So if you are often seeing men in your clinical practice or within, you know, casework, you are helping with the partners too, and you notice mood changes with them, this is not a terribly uncommon thing for them to experience as well. 34% of pregnancy-related deaths during pregnancy or postpartum were related to a mental health condition. So pregnancy-related, I want to clarify, is that there was a recent pregnancy, whereas pregnancy-associated is a complication secondary to pregnancy that caused the death. So just want to clarify there. But to be clear, these big scary things that we think about from a medical standpoint, like postpartum hemorrhage or amniotic fluid embolism or cardiomyopathy that may present as a medical complication to pregnancy, we are at greater risk of having a death from a mental health problem versus any of those big scary medical things that we think about in pregnancy. Just a few presentations of how the media has portrayed perinatal mental health disorders. So socioeconomic status is not a protective factor for these conditions. This is kind of a universal experience, and we'll talk about some of the cultural changes too that we see with perinatal mental health disorders. But Hayden Panettiere has had a very public presentation of her postpartum depression that led to alcoholism. Same with Serena Williams. She's been very forthcoming with her experience with postpartum depression as well, and medical complications secondary to her pregnancy. Some cultural considerations, again, we kind of have seen that this is a universal experience. Postpartum depression in particular is not necessarily different. Some of the data that we have is not super clear from, as you know, we don't have great research, but it seems that what is experienced in other countries is very similar to what we experience here. Important things about screening for mental health disorders. Postpartum Support International kind of gives us a lot of guidelines for what that screening looks like. So PHQ-9 or the Edinburgh Postpartum Depression Screen, those are recommended at the initial OB visit, once in the second trimester, once in the third trimester, and then at the 6-week postpartum visit. The pediatrician, there are guidelines that support that the American Academy of Pediatrics does recommend that we are screening moms at well-child checks. So, you know, they're going to be seeing the mom more frequently likely than the OB office is going to. I don't know if what your experience has been in pediatric offices is that, but that is really a good way for us to identify perinatal mental health conditions. So if you think again back to the big scary medical things that we're screening for at literally every single OB prenatal appointment, we're checking blood pressure, we are checking for urinary tract infections and glucose in the urine. We are doing all of these other screenings that are at less than 10% women are experiencing, but we know that 20% are going to have a perinatal mood disorder. So why aren't we doing additional screening if we're looking for these other, you know, medical complications that happen at a lower frequency at every single prenatal appointment? So what are the risks of untreated or undertreated perinatal mental health disorders? We know that preterm birth is an increased risk. Low birth weight is a risk, as well as development of preeclampsia. We also think about potential bonding disturbances that may be experienced in that postpartum period. If there's avoidance or anxiety can really inhibit that, the bonding that mom and baby are able to have. Additionally, there has been some research that tells us that elevated intrauterine exposure to the hormone cortisol, which kind of naturally rises in as like a part of our fight or flight. So think overly anxious mom, that increased cortisol exposure, there is concern that there are some developmental changes as well as impaired learning development and those kinds of things. What about maternal impacts of untreated or undertreated perinatal mental health? Oftentimes, like Hayden Panettiere, we seek out other substances to help deal with the emotions that we're experiencing. Relationship discord with their partner, difficulty maintaining their care. They're not going to their OB follow-up appointment. They're not taking their child to the pediatrician for their well-child checks. They may not be able to function to make it to work. And then in turn, child abuse and neglect is also a potential risk. So what do we know about risk factors? Some of those that are kind of built in. We think that there is a genetic risk factor that may increase the risk of perinatal mental health disorders. We have some evidence that tells us that at other periods of time in a woman's life, if she has experienced mood disturbances related to her period, or if they have previously been diagnosed with PMDD, so they have increase in mood dysregulation, irritability, anxiety, suicidality, depression symptoms, like the last 10 to 14 days leading up to their period, that they may also be at increased risk related to perinatal mental health conditions. Endocrine disorders like PCOS, diabetes, as well as thyroid. We know sleep disturbances are frequent in the fresh newborn period, and as well as psychiatric mental health history, a history of depression or anxiety that's, in remission going into pregnancy, postpartum, they are at higher risk. Some additional psychosocial risk factors to consider: intimate partner violence, poor social support, things like birth trauma. If they have a birth experience that is less than ideal, that can really kind of set the stage. I think of one of my clients in particular had a very uneventful birth by our accounts, but something happened within the birth itself that, again, to most of us would not seem all that significant, but to her it was. And we were on a roller coaster, and she was in a really dark place really quick. So there are some just kind of instances that to us, especially as care providers, it doesn't seem, especially if you're working in L&D and OB, you've seen really traumatic births, and that is kind of in the eye of the beholder for sure. Family history, another kind of anecdotal in my own clinical practice, what I see, if I have a mom who is been well established in her career and is successful, leans more towards like the type A perfectionistic type personality, and they're having their first baby in their 30s, I've got them pegged. They're probably going to experience a difficult time postpartum. It's important to rule out some of the medical things that can also mimic some of these. We know postpartum thyroiditis is a real thing, and that can increase anxiety and sleep disturbances and cause a lot of the physical manifestations that we kind of think about with anxiety. And then also just being diligent with our history taking and making sure that we're ruling out substance use or abuse. With regards to specifically depression, it's hard sometimes to differentiate in pregnancy, is somebody depressed or are they just pregnant? So some of the things that we think about, sleep disturbances are obviously very common. Reduced energy, but they really shouldn't be feeling like they are just kind of apathetic or not really feeling joy, not able to experience that. There also shouldn't be issues on their self-esteem related to the pregnancy. So if they're now all of a sudden having kind of negative self-talk, that's probably not from the pregnancy. When we're talking about postpartum depression, we utilize the criteria for major depressive disorder. And I like to joke that like most of Indiana in the middle of January meets criteria for major depressive disorder because it really only requires 2 weeks of you not feeling super great. So sleep disturbances, increased fatigue, recurrent thoughts of death, feeling low self-esteem, worthless, not able to experience pleasure or joy. How this may kind of present for your patients is they may just feel overwhelmed. They might not be connecting with their partners or their baby as we expect. They may not be able to take care of themselves. They may be not eating, not showering, like really those kind of baseline things that we think about as far as activities of daily living kind of might go out the window for them. We frequently see this as kind of a comorbid condition with anxiety. So things that can kind of play into that, this is what I hear a lot is like, all of a sudden, my freedom is completely gone. I can't leave. And if I leave, I can leave for an hour because my baby might need to feed them. So that kind of loss of freedom and the role shift and identity change is just so big. Another thing I want to point out, I recently had a client who had no issues through the entire pregnancy, and then quickly postpartum we were in crisis. And it kind of came up out of the blue. And I think what we found was her interpretation of what motherhood was going to look like was everything that she had seen on social media. And we all know that is not at all the case. So when that reality comes to be, that our life does not look like Mallory Irvin's living fully life, and that reality hits, it's hard. So what do we think about when we're talking about treatment? We think about psychotherapy and medication management as kind of our first line treatments for those. The studies that we have show that utilization of both of those in conjunction is going to be the best outcome. So I am always, if I'm seeing a mom at the beginning of her pregnancy or for preconception counseling, I am telling them that we've got to get a therapist on board, because being able to do some postpartum planning in particular, and even just having this lens of mindfulness around that postpartum depression or a postpartum anxiety disorder is a potential, is sometimes just enough for us to ward that off. Same with anxiety, 3 or more of these symptoms. That generalized anxiety disorder is over a duration of 6 months. Of course, we can have an adjustment disorder postpartum where they're overly anxious and on edge and constantly worried about the health and safety of the baby, checking things. Sleep disturbances are pretty frequent. Oftentimes these moms will, if you are boots on the ground seeing these moms in their living situation at their home, or you're talking to them, they are going to have 14 apps that are fully updated with the last time that their baby peed and pooped and how much they're eating at every meal. And they are going to have them very well regimented. They're going to look like they have it all together. And they might, but it is very likely a manifestation of their anxiety. And it may not come to the forefront. They may not recognize it as that. They may this is how I'm being productive, and look what a great job I'm doing taking care of my baby. Appetite, we'll talk a little bit more about that in a few minutes as well. It is sometimes difficult, especially with first babies, to identify, is this normal parent anxiety or is this over the top anxiety? And differentiating that can be difficult. Anxiety, we have really great data with regards to cognitive behavioral therapy and anxiety treatment. Again, SSRIs, depending on the severity and how long it may take them to see a therapist, is definitely a consideration as well. Postpartum OCD is, in my opinion, one of the most, it's just truly debilitating. The cases that I have seen have just been really, really challenging. And this can manifest this can be sneaky sometimes to really diagnose, but really kind of what we'll see is intrusive thoughts, which about 80% of women will experience postpartum anyway. But these are unwanted, often very distressing, often thoughts of like, what if I just threw my baby downstairs? Or walking past a knife block, what if I just stabbed my baby? Sometimes they're sexual in nature. So if you are seeing a mom postpartum and you have the ability to, before asking these questions, because oftentimes they will not tell you. I've had moms sit in my office crying because they did not have the guts to tell anybody else that they had intrusive sexual thoughts about their baby, which can be very normal. But if you can normalize that before even asking the question, hey, sometimes moms in the postpartum period will experience intrusive thoughts, and sometimes it's about hurting your baby, and sometimes it's sexual things, and you're like, where in the world did this come from? If you can normalize that, they're going to be much more likely to let their guard down and share that information with you. The difference here between like an OCD and more on the postpartum psychosis state is that these are unwanted and distressing. Whereas in more of the psychosis type state, they don't have the insight to realize that these are distressing thoughts. and those are more along the lines of like that delusional thought pattern. So that's kind of where those can be differentiated. So recurrent or persistent thoughts, urges, or impulses that are intrusive and unwanted. And then a compulsive behavior often comes out of that. Sometimes there are like mental compulsions that come out of that. Sometimes it's checking the Owlet app. Sometimes it is walking in and touching their baby to make sure they're breathing. Sometimes it is, oh, the laundry touched my shirt when I moved it from the washer to the dryer, and now I have to rewash it all. Some of these things can become so severe and so debilitating and so time consuming that it is just really just very intrusive. So this is kind of the OCD cycle that we see. So the anxiety presents itself, which leads to the obsession presents itself, intrusive thought, and then the anxiety followed by the compulsive behavior in an attempt to alleviate the anxiety, and then it just kind of perpetuates. So that can become very, very time consuming. You think about how much laundry you're doing in those early weeks, and if it literally can't touch anything as you're moving it from the washer to the dryer, that takes up a considerable amount of your life. Yeah, very similar here. These women may present as you may feel uncomfortable talking to them if they are open and upfront regarding the intrusive thoughts that they're having. So you'll definitely, want to take that seriously and send them, have them be referred to somebody that is trained in perinatal mental health for sure. But there really is, there is no intent, and the risk for harm coming to the baby is low. Treatment modalities, they're for OCD specifically. Exposure and response prevention therapy is kind of the gold standard for OCD treatment. ICBT and utilization of SSRIs, often at fairly high doses, is what we require to really target those obsessive thoughts and compulsive behaviors. PTSD is something that we can kind of see as a result of birth trauma. We can see a resurgence of some of those behaviors and the hypervigilance that can sometimes come as a part of PTSD response if there's past sexual abuse, and then, the impending expectation of what is going to come with a birth, and that exposure can sometimes lead to increases in some of those symptoms. So DSM PTSD criteria include the initial stressor, which is either the direct experience or the witnessing of a traumatic experience. And then the additional criteria, this is a month after the event. So these symptoms, must persist for at least a month after the traumatic event, but can have significant impairment, flashbacks, nightmares. They are avoiding certain places or people or experiences, and then they negatively kind of have some of the mood disturbances that come along with that, with the hypervigilance and the irritability and quick-tempered, angry, those kinds of things. So potentially traumatic events, and this is probably only just a handful that we could get from a particular birth experience. So C-section, labor that doesn't go as we expect, miscarriage or stillbirth, unexpected NICU admission and an extended NICU stay, preeclampsia, HELP, even hyperemesis gravidarum for some. Just the experience of that initial first trimester can be really challenging. Recurrent themes in birth PTSD include the feeling of abandonment, feeling poor communication. They express feeling powerless in that situation, and then being invalidated in their experience. And again, for those that are seeing women, whether you are on an OB floor or see them very shortly after, sometimes just I remember like debriefing with my midwife after one of my like literally standing in the delivery room like debriefing what just happened, and like what a gift that was to be able to, and she didn't do that for me just because I was a medical professional, just like to be able to kind of talk through that, and so that didn't fester and manifest. But really trauma is very much in the eye of the beholder. So if what you experience, again, to those that are in OB and are doing emergency cesarean deliveries every day, and have, you know, very sick patients frequently, it may not be that big of a deal. Or you may reassure yourself and say, well, my baby lived. Well, my baby didn't go to the NICU, or yeah, I had a postpartum hemorrhage and I needed a unit of blood or whatever, but like I'm fine. So just being able to kind of validate that experience for them is oftentimes really important to their healing. So birth PTSD in particular, you know, if it's has something to do with a particular provider, the way that you were cared for, you may not go back for your follow-up appointments to see your OB or midwife because of that particular experience. So treatments that we use for PTSD, really EMDR, brain spotting are all really good psychotherapy modalities, and sometimes it just really is important for us to be able to kind of step in and manage some of those symptoms. So whether that's sleep disturbances with sleep medication or SSRIs. Okay, I'm running out of time, so I'm gonna fly through some of these. Bipolar disorder, what I really wanna point out with this is oftentimes with medication management, especially in pregnancy, if someone has previously been identified as having bipolar disorder, we know that there's a potential risk of manic episode, postpartum, or postpartum psychosis occurring. And so we oftentimes I see clinicians feel more safe if they are on a mood stabilizer or an antipsychotic medication and an SSRI. They might feel okay with the patient continuing on their Zoloft, but they don't want them to continue on their Abilify. So they take them off of their Abilify, and now we're just on an SSRI, which serotonergic medications can increase the risk of hypomania or mania. So it is important that we maintain both of those and don't just kind of pick and choose what we feel safest about. But just also knowing that if you're coming across a client that has a bipolar diagnosis, knowing that their postpartum risk is increased and that it is imperative that we continue those medications and that they're seeing somebody that feels comfortable maintaining those medications in pregnancy as well. Bipolar disorder is often misdiagnosed as well as unipolar depression. Most of the time people won't seek care in manic episodes because they generally feel pretty good. But once they're depressed, they're quite depressed. And so if you're not asking the right questions, that can be missed. Postpartum psychosis. So this is something that occurs in 1 to 2 out of every 1,000 births. 5% die by suicide, and 4.5% commit infanticide. 50% of first-time mothers have no prior psychiatric hospitalization, and generally the onset of postpartum psychosis is within the first 2 weeks postpartum, and this does require emergent evaluation. Some of the media portrayal recently of postpartum psychosis in particular, Andrea Yates drowned several of her children in the bathtub, and then Lindsay Clancy was actually an OB nurse, suffered with postpartum psychosis and harmed 3 of her children as well. As I said, this is an emergency and requires hospitalization. Eating disorders in pregnancy. I see a lot of patients with eating disorders that are not pregnant, but I also many of them become pregnant. Just like a word of being mindful of the way that you're interacting with these clients. This can be a really triggering time for many women that have previously had eating disorder. Even if they're in remission, it is really important that we are not commenting on the way that their body looks. That we are, if they ask to be weighed backwards and to have that taken out of their chart and, you know, to have the BMI removed, please, there is a good reason that they're asking for that. And, you know, just know that not, you know, many of us experience body dysmorphia in pregnancy and postpartum. So just be mindful of that. So how does these things apply to your nursing practice? Educating your clients on perinatal mental health disorders, what to look out for. Again, a lot of that postpartum planning and just giving them the lens that this is a possibility and a consideration that, you know, is possible. And so just to kind of have everybody on the same page that their awareness is there. For many that are speaking with these clients on a fairly regular basis, or if you are going into their homes and seeing them, you might be the only one that is consistently speaking with them. So when I think about care in the OB space, I think the value of seeing a provider, the same provider, throughout the duration of your pregnancy and postpartum is very much spoken in this perinatal mental health space, because I know what my patient looked like when she was 20 weeks pregnant, and now I'm seeing her 6 weeks postpartum and she looks bad. Her affect, she has a flat affect. She is not the same person that she was, you know, prior to having this baby. So if you are in frequent communication or consistently laying eyes on clients, just know that you might be the only one seeing these changes, and it's important for you to investigate. As far as medications go, encouraging higher level of care prior to discontinuation. If you're answering the phone at the OBGYN office, or you are you know, seeing a client who's had a baby not too long ago and now found out that she's pregnant again, just do not tell them not to discontinue any medications. As Dr. Turner said, majority of medications we are going to continue and maintain during pregnancy. And then again, just validating traumatic birth experiences, being willing to share that space with these individuals who have had birth experiences that maybe weren't what they were expecting, and being able to kind of sit and process that with them is important. Additional resources, Postpartum Support International does offer the perinatal mental health certification. MassGen has some good information and additional continuing education on their website, Mother to Baby, and then locally Mission Motherhood has some great resources as well. Thank you.
Thank you so much, Delaney. I will say too, her PowerPoint did not look like that. It was a really nice Canva, but I think when it was exported, the formatting was affected. I know that we are at time, but does anybody have any questions while we have Dr. Sarah Turner and Delaney here with us that you would like to ask? Okay. Well, thank you. Yeah.
I was depressed. I had depression with my first, so much so that I like can't remember the first 4 months of his life very much. And so when I got pregnant with my second, a very, very wanted, very planned pregnancy, I was so indifferent. Like I could not have cared less that I was pregnant. People would be like, "Oh, it's so exciting," and I would literally be like, "Yeah." And I went on all our doctor boards on Facebook and I was like, what is wrong with me? Like, is this depression? What is this? And everyone's like, no, it's the second pregnancy. You're so busy with your first that you can't enjoy it the same way. And there's this huge part of you that's like mourning the loss of that only childness. Is that other kid gonna hate me for some reason? And the kids will say it. I have a patient who delivered a month ago, and her son was like, I hate you, Mama. I hate you. She goes, do you hate Daddy too? Nope, just you. And I'm like, and she'd be in my office like crying, and I'm like, you know, he'll get over it. But I feel like I try and bring this up in anticipation with a lot of my patients during that second pregnancy. Hey, have you had the thing yet? Just because I feel like a lot of them are like, what is wrong with me? Like, I wanted this baby. Am I depressed? It can obviously become depression, but it's also a super normal thing that I feel like disappears in the delivery room. The second the baby comes out, they look at them and they're like, okay, everything's great and the world is perfect. But and we're taught about it, but I feel like it's so common. So I just wanted to mention that. Fathers, I feel like one thing I talked to a lot of the fathers, and I feel like I didn't, unfortunately, I feel like Postpartum Support International changed how I practiced so much because I knew that men would go through stuff, but I never realized how common it was. And so now I actually try and bring it up with them a lot. And I'm baffled at how many of them may not actually have depression, but they feel like useless at the beginning, especially because a lot of them want to be in this role of I'm going to help and protect and take care, and they can't, especially with breastfeeding moms. And so again, bring it up. Hey, do you feel useless? Do you feel like a third nipple? Because you kind of are. But I feel like, again, acknowledging it and just being like, it's okay for you to feel like that. I feel like Fort Wayne doesn't have anywhere near this sort of support for dads. Magnolia Tree has a dads group that recently started. That's great. It's called Rooted in Fatherhood is what it's called. And I think in 2025, it's just the dads, and in 2026, they can actually have like things, bring your baby and we'll do stuff together. But I don't know that they have the same thing with the second baby, but they absolutely go through stuff. And we do a terrible job in medicine. We are not trained well about any of this. At 3 pregnancies, never once was I screened for postpartum depression, ever. Never once have I been trained to screen anyone for postpartum depression. The other thing that really sucks is insurance doesn't cover it on the pediatric side. And I've had patients come back and be like, why did I get this bill? And then they get angry at me. So I just learned not to I just don't bill for it. But we fail. 100% we fail in this entire area. And I'll be the first to admit it. So yeah.
Does anybody have any other questions that might be helpful? Yeah.
I was just gonna ask about like Lamaze classes or like birthing classes, just because I know that would be a good way to engage women like upfront, and those things are not really offered no more. I don't know if it had anything to do with COVID or just people don't offer it, but I was curious.
I know, I think Parkview does as well, but Lutheran and DuPont, we have prenatal classes. It's unfortunately one day, but it's like a 9 to 4. They go through all this stuff. You're with other parents. And I try and get most of my first-time moms to go because I'm like, at the very least, you'll meet some other moms that, you know, might be due around the same time. I feel like, too, the breastfeeding groups, which ours actually is now just a mom's group because we want everybody to be able to come. But those are another great way to kind of help protect and catch them before they fall, I guess. But yeah, I feel like I think Parkviews and DuPont and Lutherans are all like one day, which is unfortunate, but I also feel like there's got to be something for the people that are too busy to do the other ones. I don't know, we should maybe have more options, but it's a good point. Which one? Is it online?
Okay, she's saying that there's something at the Family Resource Center. There's prenatal support and incentives program, and I know that's located over at Bridge of Grace. I did have a question for Delaney. Delaney, are there any tips, as a lot of the guests that we have here are working directly with families, um, and I did so back in my day as well, for identifying or really bringing up some of those symptoms that are of what you spoke about, right? I had a loss when I was working with a mom, and I will tell you that haunts me till this day because I go back and replay what did I miss? Did I not ask the right question? And the only thing that I can continue to remember is that she would not get any sleep, and then she would say that she wasn't tired. And, it's after the fact, and I'm not a professional in the profession that you're in, but is there any things that you think are worth bringing up when, you're working with these moms that are already very vulnerable, very high risk because of so many of the, things that they have going on in their lives that would be helpful for everyone here that's working with these moms?
I think just really kind of focusing on some of those very basic, like ADL activities of daily living, like are we sleeping? Are we eating? Because those are kind of like the first things that we see shifting, and so those feel very like superficial to the person that you're asking. They don't feel like deep, penetrating questions. It just really kind of feels focused on them as an individual. And so I think that those kind of very simple things are will be hopefully responded to transparently and will be a good starting place to kind of start that initial conversation. Just very much focused on those very simple things that are necessities of life and important, but are very evident as to overall wellness too.
The mom who was a labor and delivery nurse, if you look at her case, everything was done right. Her doctors, her team, her family, they addressed everything. And so we can do everything right. You can't blame yourself. It's normal to do it, but sometimes they can't be helped. And I hate to say that, but everything was done right for her. She had so much follow up, so many people on top of her, and it still happened. In the 20 minutes that her husband went to go get food, that's when it happened for her. And he otherwise quit his job, he hasn't quit his job. He went on FMLA, stayed home with her. He was a physician as well, and he was with her 24 hours a day, except for that 20 minutes. So sometimes everything should be done exactly the way it's supposed to, and it still goes.
Questions? Well, thank you guys so much. I know that we stayed a little bit longer, but I definitely think it was worth it. These are so helpful. Again, Dr. Turner, Delaney, thank you so much for your time and your hectic schedules and for everything that you do and for everything that you guys do because, you are out there working with a really tough, vulnerable population when we ourselves are struggling on some days. So shout out to you guys and thank you. And I hope that everybody has a Merry Christmas. We have a little short survey, which is really